So today we're going to talk about managing co-occurring alcohol use disorder. We have no disclosures. The objectives are to learn signs and symptoms of the alcohol withdrawal syndrome and to properly manage alcohol withdrawal. And this is going to be, I know we have some folks who work in the hospital, this will be namely in the outpatient setting, and become familiar with the FDA-approved medications and psychosocial interventions for treatment. So we'll start with the case. Ms. A is a 41-year-old female with a history of hypertension and opioid use disorder, presenting to your clinic for a follow-up on her blood pressure. She's been taking her buprenorphine, her HCTZ, and lisinopril, which are blood pressure medications, and she tries to follow a low-sodium diet and a regular exercise routine. She quit smoking 2 years ago, but she does report daily alcohol use. And on her exam, overall it's normal, but her blood pressure is a little high at 154/98. So you're worried that the blood pressure could be related to her alcohol use. And we want to know, does she have a pattern of risky drinking or does she have an alcohol use disorder? So just to review those definitions, and before we review those definitions, just to review our standardized drinks, because that's part of the picture here, making sure when we're talking with our patients that we know how many actual drinks they're having. Here in the US, that's 0.6 fluent ounces of pure alcohol or 14 grams. And you can see some examples there. So when someone tells you they have 2 glasses of wine a day, you're going to want to, for instance, define that it is actually a 5-ounce, if that's actually what they're describing as their 1 glass. So what is risky drinking? And it's important to know this kind of in terms of distinguishing it from alcohol use disorder. So the National Institute on Alcohol Abuse and Alcoholism, or NIAAA, defines it as following for adults who are not pregnant. So for women, that's no more than 3 drinks in one day and no more than 7 drinks in 1 week. And for men, 4 drinks in one day and 14 in 1 week. And so importantly, like if they have 3 drinks in one day, more than 2 or 3 days a week, that's actually going to be more than the 7 drink a week total, or are they having less than the 7 drink total in 1 week? So that's the limit for risky drinking. Espert want to just talk briefly about that model here because it's really meant to kind of help engage patients early on. So if they're if they're experiencing risky drinking, Espert can certainly be helpful. There's a lot of evidence. USPSTF gives it a grade B to screen for unhealthy alcohol use. And it's a very brief intervention that assesses use, and the goal is to reduce the risk of negative consequences of use, so helping to get people, the assist and arrange is if you do identify unhealthy use, to help people get help early. So then screening for risky drinking and alcohol use disorder is key in all healthcare settings. Really, in primary care, we should see this everywhere now. We start with a single question approach, which is how many times in the past year have you, for a man, had 5, and for a woman, 4 more drinks? And that's based again on that risky drinking number to identify perhaps a binge use pattern. And if that results positive, then you'd want to assess it further using a validated tool such as audit, which we'll look at here in a minute related to our case, or one that's more appropriate for a particular population. So MASG for a geriatric population, and CRAFT for adolescents. The CRAFT, just to kind of go over what that is really particular for adolescent use because it really normalizes it for their age group in terms of getting them more comfortable to talk about use. So considering a lead-in about friends' use and avoiding ambiguity, but really talking about these items that have you ever ridden in a car driven by someone using? Do you ever use to relax, fit in? Do you ever use alone? And then do you ever forget things? The second F is if family or friends have told you to cut down, and have you gotten into trouble while using? But back to your patient, she responds yes to that first question screen about heavy alcohol use. And so you do administer the audit C, and she scores a 7, and we'll look at her actual score on the next slide. But on further discussion, you do learn that she's got a significant fear of stopping use. And she had withdrawal a couple of years ago. That was resolved when she returned to alcohol, and it's interfering with her home life and work, and she's asking for your help. So those are all things that are criteria more in the alcohol use disorder category that we'll talk about. Here's her audit C. So she's scored 4 or more times a week. That on a typical day, she'll have 3 or 4. And 6 or more on one occasion she scored a 2. So you can see here that a score of over 2 identifies 84% of women. A score of over 4 identifies 86% of men. And so audit C is a nice, relatively quick way to determine how significant is somebody's alcohol use. But then we want to know if they have a use disorder, right? And so that's when we're going to our DSM-5 criteria that we use for many other substances. And it's really can kind of be grouped into the 3 C's, if you will. So cravings, compulsions, and consequences of use. And if someone has at least 2 of those, and then there's tolerance and withdrawal are the other of the 11 criteria. If someone has at least 2 of those, then they would meet criteria. And I think if we went back and saw what she was reporting in terms of her withdrawal in the past and how she's experiencing some consequences already of use, however, continues to use, she's definitely meeting probably at least moderate criteria for AUD. So what treatment can you offer? Just to briefly talk about treatment rates in the US, they're pretty low. Only about 6.5% of adults and 5% of youth with AUD in the past year received treatment. Less than 1 in 10 people in the US with a diagnosis of alcohol use disorder in the last year received treatment of any kind. Over 90% of community programs only offer do not offer medication, so offer group counseling and referral to AA. And also both racial and ethnic minorities experience, as with other substance use treatment, barriers to help. So particular importance to focus on getting people into treatment. And this is especially the case for women. So what are when you're considering treatment, we need to consider there's 2 main aspects, right? There's management of acute withdrawal and then relapse prevention. And so when you're seeing someone initially, again, this is geared more towards outpatient setting, but same could be said for inpatient. But when you're seeing someone initially, you're determining, first of all, if they are someone who can do an outpatient taper with a brief benzodiazepine taper to get through the initial withdrawal. And if they're not, and the main reason why they may not be is if they've had a prior history of complex withdrawal, so seizure, DT, then they would need inpatient. There's some other things such as high risk medical comorbidities, pregnancy, other things that might warrant that. But if they are determined to have a low risk and can proceed with an outpatient withdrawal, the benzodiazepine taper is the mainstay for that. And then we can consider some other medications that may help ameliorate some of the symptoms of withdrawal, but would not, such as gabapentin, but would not be for seizure prevention. And then, so we're figuring that part out first. And then at the same time, we're starting to think forward about what can we do to help prevent relapse. And we'll talk about some of those medications next. But before we do, here's just an example of the CWA scale. So this is very small on the screen, sorry, but you all have, if you've worked inpatient or in an outpatient setting, you've probably seen this. It's basically looking at both subjective and objective criteria for alcohol withdrawal. And really, you can see in the score box there that once you're getting above a 15, if someone's scoring high, then they definitely need medication to help with that withdrawal. And if you're getting up into the high teens, we're looking again as that being a potential reason for being hospitalized, especially in the acute first 24 to 72 hours. So we know from lots of studies, here you can see a 2010 Cochrane review of 64 RCTs, that benzodiazepines are effective to help prevent alcohol withdrawal seizure when compared to placebo. There's really not evidence for the use of other medication, but as far as anticonvulsant medication, carbamazepine may be more effective when compared to oxazepam and lorazepam in treating some aspects of alcohol withdrawal, and could also help decrease drinking extent after that acute detox period. In some cases, there may be a role for gabapentin in mild withdrawal, but again, these are for other symptoms of withdrawal, not for seizure prevention. So you assess your patient further. We're administering that SIWA here in clinic, and she scores a 12. She doesn't have a high-risk history. She does have support at home, and so you review the options of inpatient versus outpatient, discuss those risks, and agree with her decision for an outpatient detox. So she goes home, she returns after a successful taper, but when she returns to she does report strong urges to drink. So now let's talk about what meds we might offer her. So, sorry, the next couple slides are a little bit wordy, but just to kind of summarize the evidence for these, we basically have 3 that are FDA approved, and then some off-label ones that have some evidence as well. But naltrexone is the one really with most use in I would say in primary care. We use it here quite a bit as well. In our patient who's also on buprenorphine, this is hard because it's an opioid antagonist, so we wouldn't be able to, but definitely want people to be comfortable with this in general in terms of offering this as treatment. So it blocks the effects of naturally released opioids that are released by alcohol consumption, so those endogenous opioids. And in doing so, it decreases so the euphoria that's experienced with alcohol and decreases the chances of an extended relapse. So basically, if someone has alcohol, oftentimes people think that if they're on naltrexone and they're going to drink, they need to stop it because it will make them sick. And we want people to continue on either their oral or long-acting Vivitrol monthly injection. Because if they are going to have a drink or be in a higher situation where they may drink, this is really what the evidence is showing, is that it should decrease the risk that one drink may precipitate a more extensive relapse. Usually this one's pretty well tolerated. Again, it's contraindicated in someone who's on opioids due to that antagonist effect, binds the mu receptor really strongly and can precipitate withdrawal. I should probably alter this, that we do try to check at baseline liver function and also, following initiation of this medication, but it definitely should not be preclude treatment. So if someone is ready to start, we have good guidelines from SAMHSA now to go ahead and get the medication on board. Again, it can be started while someone's still drinking. So what did we see with a Cochrane review of 50 RCTs, almost 8,000 patients, that oral naltrexone decreased that relapse to heavy drinking to 83%, the placebo risk with a number needed to treat of 10, and decreased drinking days by 4% and heavy drinking days by 3%. So a really good medication. We do tend to see that for some people, they have a really strong response to it, and helpful medication, and others not so much. There may be some genetic component to that as well. This is the combined study that looked at, this is the biggest study that looked at treating AUD. It was conducted at 11 sites in the US. And it basically supports its use in primary care because it looked at different arms where patients were randomly assigned to placebo and or acamprosate, and which we'll talk about next, and or naltrexone, and all with medical counseling. And those who had naltrexone and medical management, so basically just going in and meeting with their provider, and those with placebo plus the CBI session had the most substantial decrease in days drinking. So this is really what, at least in primary care, is good evidence of providing this treatment. So our second FDA one is acamprosate. This is an amino acid derivative that increases GABA transmission. Sought to stabilize the glutamate receptor, and can help alleviate, and doing so can help alleviate some of the physical and psychological symptoms it has a sort of a strange daily dose. So it's 2 large pills for a total dose of 666 milligrams to be taken 3 times a day. That dosing schedule can be very hard for anybody. And so if it is, but patients want to be on that medication, sometimes taking 3 twice a day is an alternative. A good thing in terms of benefit for acamprosate is if someone has cirrhosis of the liver, has certainly class B or C, or there's significant concerns with their LFTs. This one's processed by the kidneys, and so would be safe. The Cochrane review of 24 trials showed acamprosate decreasing that relapse to alcohol when compared with placebo. And seems to have a more important role in preventing relapse in someone who's already been abstinent for at least a couple of weeks, but it can also be taken when someone has alcohol. And then disulfiram is the third one, but we don't have very good evidence for this. This is otherwise known as anabuse, and it's the one that causes that disulfiram ethanol reaction if someone comes into any contact with alcohol. So it can be very, very uncomfortable with those symptoms listed there. Do need to monitor liver function, and also not good to use this in someone who has significant cardiac disease. And it's really, for that reason, contraindicated if someone does not have a goal of total abstinence and can't be started within 48 hours of their last drink. So for some folks, people insist on this one, and oftentimes it's maybe a job requirement or something that they feel like is the last sort of thread they need to be able to stay off of alcohol. And where it's most effective is probably if someone's taking it under supervision, but there may be some cases where this medication is indicated, but we don't tend to offer it at first. And then some off-label medications, topiramate, 7 RCTs showed more days abstinence and less binge drinking than placebo. You have to kind of start this one gradually and amp up to try to decrease side effects. Women have to be on really good birth control, and it can have some significant side effects. Gabapentin is another one, especially when there's sort of more of an anxiety component to drinking. And so meta-analysis of 7 RCTs only showed effect on the percentage of heavy drinking days. The target dose that someone would be on is 12 to 1800 milligrams. So sometimes with the sedation that this can cause, it may take a little bit to get up to that effective dose. And you do have to be cautious, as gabapentin does have some potential for misuse. So the current APA guidelines are naltrexone acamprosate, or acamprosate would be recommended for treatment of moderate to severe AUD. And then topiramate and gabapentin may be for patients with moderate to severe, usually after first trying naltrexone or acamprosate, and that disulfiram should not be first line. So how do we decide, just to kind of bring this to a close in the next few minutes, which medication to take? You do want to consider those coexisting medical comorbidities that we kind of touched upon, both with, for instance, with liver disease, potentially, also if they're on other opioid therapy, etc. What are their prior experiences with treatment? What didn't work before? Maybe why didn't it work? How was it tried? What worked before? Usually would work again. So that's important information. What's their ability to take medication at a certain frequency? If they're a candidate for naltrexone, but it's really hard to take a medication each day, that one has the benefit of having a monthly injection. And considering psychiatric comorbidities and the need for treatment of co-occurring mood and substance use disorders. So all of those things can be part of the decision. And that last point, there was a double-blind trial of 170 patients that did show significantly higher rates of abstinence from alcohol with naltrexone and sertraline than with either alone. So important to be treating, not just the alcohol use disorder, but what else is contributing to someone's overall picture. So question for you. What should we do with her buprenorphine prescription in the case of ongoing or return to alcohol use? And sorry, I have not been pulling up the chat here, and I will look at it at the end. But, just kind of think about what would you do in the situation if you had someone coming in and she was, normally really stable on her buprenorphine, and maybe say on a month with a couple of refills, but she was, maybe drinking pretty heavily. So usually we definitely don't want to stop buprenorphine or decrease the dose, but we want to make sure we're providing perhaps increased support and visit frequency. So maybe shortening, the going over the risks of combining alcohol with this medication, but also trying to see her more frequently. And then also making sure that we're reassessing, the effectiveness of the treatment that we're providing for her AUD. And also checking in on the liver function periodically. And then just to briefly touch upon behavioral intervention, there's certainly a lot more to be said about this, but just in the interest of time, the brief intervention as part of that SBIRT model, again, this is really very useful for alcohol use, especially when it's early on, but a meta-analysis of 34 studies showed that those receiving a brief intervention ingested 20 grams less, or 1.5 standard drinks, than those in the no intervention groups after a year, but little difference shown on the frequency of drinking or binge drinking days. And these interventions can include feedback model, responsibility, advice, providing a menu of options, showing empathy, work on self-efficacy. And they typically lead to a 20 to 30% reduction in heavy drinking with significant effect for up to 2 years. And then, of course, motivational interviewing has a lot of evidence showing benefit. And again, in the treatment of AUD, it's found to be most effective in the first 3 months with younger populations who have occasional heavy drinking but low clinical dependence. And then our mutual help /AA can be effective for many people. It might not match for everyone. And I always make sure that people have certain groups might not meet kind of where they're at, or might not support medication, for instance, just to make sure if a group model does seem to be helpful, make sure they find one that meets them and their needs well. It's been shown to increase days off alcohol at both 3 and 15-month follow-up, but a Cochrane review of 8 trials didn't show evidence of efficacy as a standalone intervention. And then family involvement, certainly when helpful, has been shown to reduce drinking in 5 trials. So to close our case, we obtained our baseline renal function tests, and I guess I should have put in there too that we're checking on her liver just to see how it's doing. But she opts for starting a Camprosate. And after a week, she's at her goal dose. And you encourage her to keep taking the medication. She's also going to meet with the psychologist in your clinic for CBT. And at 1 month follow-up, she reports she had 1 lapse last week, but that it didn't lead to a prolonged relapse, and she hasn't had any alcohol since then. Her blood pressure is also normalized. She does screen positive on your PHQ for depression, and so you decide at that point to add sertraline to her regimen, and she reports improvement in her mood. So in summary, we want to screen youth and adults on a routine basis using these validated tools that we discussed, be able to diagnose risky drinking and alcohol use disorder and offer prompt treatment. Remember that AUD is one of the most undertreated health conditions in the US, but does account for significant morbidity and mortality, and that's particularly the case in New Mexico. Assess withdrawal risk and recognize the need for inpatient versus outpatient management of that, and be able to counsel your patients regarding different treatment modalities for AUD and prescribe any indicated medication or refer for treatment to support their recovery.